The kidney connection. Are NSAIDs safe for renal patients? We've all reached for them. Ibuprofen, Naproxen, or Aspirin. Known as NSAIDs, these are the world's go-to for pain and inflammation. But for millions of people living with kidney disease, these harmless pills can be a silent danger. The core question. Today, we are analyzing the relationship between non-steroidal anti-inflammatory drugs and renal health. Why are they so risky, and what are the safer alternatives? The mechanism. To understand the risk, we have to look at how kidneys work. Your kidneys rely on chemicals called prostaglandins to keep blood vessels open, ensuring a steady flow of blood to be filtered. The problem. NSAIDs work by blocking the enzymes that produce these prostaglandins to reduce pain. But in doing so, they also constrict the blood vessels in the kidney. For a healthy person, this is usually manageable. But for someone with impaired kidney function, it can lead to a sudden drop in blood flow, causing acute kidney injury, AKI. Dangerous combinations. The risk increases exponentially when combined with other common medications. Doctors call this the triple whammy. It happens when a patient takes an NSAID, a blood pressure medication like ACE inhibitors, and a diuretic, water pill, at the same time. The consequence. This combination puts immense pressure on the kidney's filtration units. For a patient with chronic kidney disease, even a few doses of an over-the-counter NSAID can lead to permanent damage, or even the need for dialysis. First-line option. So what should you take instead? For most renal patients, acetaminophen, paracetamol, is the preferred choice for pain and fever because it doesn't affect kidney blood flow in the same way. Topical versus oral. If you have joint pain,
Take 2 aspirin and call me in the morning? Wait, maybe not. Yeah. We're going to talk about kidney disease and anti-inflammatory medication. I'm Dr. Paul Salzo.
I'm Dr. Brad Weening. Welcome to Talking with Docs. We brought Dr. Pandya back to talk all about this. Welcome.
Thank you.
And what we're going to talk about is not only anti-inflammatories and their causing of the kidney disease, but if you have existing kidney disease, is it safe for you to take a small amount or any amount? We're going to kind of go through all of it. So let's start at the beginning. How do those little anti-inflammatories that are so helpful to us, how do they damage our kidneys?
Yeah, so there's a number of things that can happen with the use of anti-inflammatory agents or NSAIDs with the kidneys. And I know it's important that we want to talk about patients with chronic kidney disease and what the risks are there, but there's a multitude of other things that can happen with anti-inflammatory agents that are maybe completely ignored, if you will.
I think you're right.
Maybe I'll just go through some of that.
Absolutely. Yeah.
So first, you can get electrolyte imbalances with anti-inflammatory agents. So things like low sodium value or high potassium, and the high potassium can cause rhythm problems in the heart. So we have to be careful of that. Your risk factors for that depend on what other medications you're on, and for any of these things, how far down your kidney disease is. So that's for all of these things. The other thing is it can cause salt and water retention, which can have a relevance, one, for developing or worsening high blood pressure, usually around the range of 3 to 6 millimeters of mercury for your systolic blood pressure. Doesn't seem like a lot, but when you look at studies, what we call epidemiological studies or studies of populations, 3 and 5 millimeters of mercury has implications from a public health standpoint on cardiovascular risk.
That's also considered a successful treatment if you drop it 5 millimeters, so that kind of speaks to it as well.
Right, and so along with the blood pressure effect, if you have a tendency towards having volume accumulation, if you have any degree of heart failure, the anti-inflammatories can actually promote salt and water retention. It can cause swelling, shortness of breath, and it's one of the causes of precipitating heart failure visits to the emergency room. Right. It's a commonly asked question if you're taking any of these anti-inflammatory agents. So electrolyte abnormalities, salt and water retention, and then, of course, there is the development of acute kidney injury that can happen if you're sensitive to anti-inflammatory agents. So the NSAIDs, essentially block the effects of prostaglandins in the kidneys. And when you have lower levels of GFR, then you actually become a little bit more prostaglandin dependent. And to maintain your filtering function and your flow. And when you block that with NSAIDs, your kidney function can drop down. Again, the development of acute kidney injury is really quite relevant on one, if you've had a history of it before.
Yep.
Two, if you're on other medications that can affect the flow in the filtering units.
Yep.
Heart failure or cirrhosis or something called nephrotic syndrome, which is a kidney-related disease where you spill a ton of protein. These are things that put you at a higher risk of developing acute kidney injury.
Now, like, how much anti-inflammatory are we talking about? Like, if I take a couple of ibuprofen because I got a headache because I've been working too hard, or if Brad takes a couple of ibuprofen because he's dealing with that bad hangover, like, are just these 2 pills gonna harm us, or is it like regular use, like over a week or 2 weeks or months?
Yeah, no. So great question. You really want to get to the chronic kidney disease part. So we're gonna get the chronic kidney. So the studies that were looked at originally are fraught with like a lot of confounding errors or things that you can't analyze them properly, and the number of patients with, let's say, more severe kidney disease are far and few between.
Right.
Okay. So there's a great review about 5 years ago that put some practicality to all of this stuff.
Yeah.
And it says, so if you have stage 1 or stage 2 kidney disease, which means your GFR is above 60, you have no added risk of developing chronic kidney disease than the general population.
Okay, sorry, GFR 60 is just below what we consider like a normal limit of filtration of your kidneys. We talked about this in a previous video.
We have a video that talks about this.
And when we talk about like stage 1 and stage 2 kidney disease, where your GFR is above 60, it means you still could have kidney disease by way of having protein in the urine or other urinary abnormalities. And so you still, if you're deemed to have kidney disease, no different than the general population in terms of the risk of anti-inflammatory use at the prescribed doses.
Okay.
And what that risk is, though, is like, I think that's what Paul's really asking. So if you have normal kidneys or even just slightly below normal kidneys, do we know what a safe amount of NSAID is?
Yeah. So first, let's talk about stage 3 kidney disease.
Okay.
So now we're like less than 60.
It's
and
maybe
you say,
easier to go back, yeah.
So if we're now less than 60, what we deem as safe is if you take short courses of anti-inflammatory agents, like let's say 5 days for an attack of gout, your risk of having any kind of progressive kidney disease with a short course of anti-inflammatory agents is negligible. Basically no risk, So you have an acute injury, you have to take anti-inflammatories for 5 days, and you 5 and done, your risk is low. Now, if you're at stage 3, particularly if you get further down into stage 3B, and you're going to have chronic use. So these are all the patients that are coming in to see you guys, right? And they're like, okay, when am I going to need my joint replaced? What can I do? The problem is, as we talked about these studies, is that we say, lots of people say, full stop, you can't use them. It's going to hurt your kidneys. And I have colleagues that do that. The trouble is that what's the alternative?
Right, they're suffering.
Or you go to opioid based medications, which have obviously all of their side effect profile that you have, right? So as a practical matter, the better your kidney function is, the more tolerable you are going to be to anti-inflammatories. If you were to have chronic use of anti-inflammatories, I think it's important to have your blood work checked, your routine biochemistry, your potassium, your sodium, your creatinine, in sort of 3 to 4 weeks, in that sort of time frame, to make sure that you don't have any significant electrolyte abnormality, number 1, and number 2 is that you're not overly sensitive to the prostaglandin blocking effects of the anti-inflammatory. And some of this relates to your physician looking at your profile and saying, well, are you on some of these other agents that we talk about using for chronic kidney disease, like the RAS blockers or the flozins, right? Or the finerenone, the non-steroidal MRAs. These things can affect the hydraulics, if you will, and that coupled with then blocking prostaglandin effects in the kidney can cause your kidney function to decline. So just a 1 check, and then it depends on how long you're going to be on it, and having periodic checks of your kidney function more than just like the annual visit, depending on where you are. Now, the safe amount is like anything in medicine. The lowest amount for the lowest duration.
Right, the lowest effective dose for the shortest period of time.
Right.
Sure.
And so it's hard to say, but what we'll tell you is that if you get to stage 4 disease, so your GFR is less than 30, you want to use these with caution. You're still likely okay to get away with the 5 days, but you should have a physician with eyes on it and having blood work. And we usually say avoid it altogether if you're stage 5 or less than 15.
Right.
All right. So stage 5 avoid, Stage 4, proceed with caution.
Is stage 6 when you have zero function? Is there a stage 6?
There's
or
no
doesn't exist?
stage.
But I mean, if you're on dialysis, does it matter then? You're like, my kidneys are gone.
This one goes to 11.
Then can you take anti-inflammatories then or no?
No.
No, you can't. Because I thought, okay, well, my kidneys are
Well, because
gone.
what we haven't,
They're toast.
what we don't talk about, what we haven't talked about, because this is a kidney talk,
Yeah.
is the GI side effects.
Right.
Yeah. No, I mean just specifically from a kidney point of view.
No, but
Yeah.
and when you ask about dialysis patients,
Right.
dialysis patients have upwards of, let's say, 5 to 10 times more the bleeding risk
Okay.
than you do.
Okay,
And
interesting.
so we say
no.
again. So,
Okay, that's good to
so
know.
this is like, so this is now beware in terms of the use.
Right.
Yeah.
And so we really frown on that, along with, you can still get problems with heart failure, et cetera, related to these things. So under 15% or stage 5, forget about it.
Get it.
If you're stage 4, basically between 15 and 30
Yeah.
for a GFR, then just proceed with caution.
Short
courses.
Close monitoring.
Yeah, avoid the chronic use of that,
Okay.
and monitor. And if you're in stage 3, which
Yeah.
is between 30 and 60, you're not at any greater risk for short courses. And if you have to do if you're doing prolonged courses of anti-inflammatory agents, you should be monitored.
And are we talking like yearly monitoring, 6 months monitoring? How do you know? Or they take the whole thing. You got high blood pressure. Maybe you have borderline diabetes. Your kidney function's still okay. We just watch it closer.
Yeah. So I think this, probably if you looked at the problem list that somebody might have, the more problems they have, the more frequently you should monitor, right? So let's give you an example. Let's say you have a 60-year-old person with a GFR of 50, okay? No protein in their urine, and they're wanting to take chronic anti-inflammatory agent use for whatever reason, right? Then you say, okay, well, let's check their blood work, and they're not on any other medications. Okay, let's make it clean, completely clean. Then you should check their blood work in 2 to 4 weeks.
Yeah.
And then you probably want to say, okay, let's just have a check in 6 months, make sure everything's okay. Now, hopefully they're not going to need, we got to treat the underlying disease and see if you can't get off of it.
Yeah.
But you should say, okay. But now let's say you have somebody who's got high blood pressure, has got some cardiac disease. That's not a patient you want to wait 6 months to see what's happening. Right. You might want to say, okay, we'll check it in 2 to 4 weeks, and then let's get another touch point in 3 months. If it's not affecting you then maybe we'll do another 6 months after that. So some of
It's cheap, it's easy, it's relative. You say, I mean, the cost of blood.
And just to be clear, we're talking about oral anti-inflammatory use, systemic anti-inflammatories. You're okay with topical anti-inflammatories in these settings?
That's right.
So that's not included in this discussion?
No, topical we use a lot, including in our dialysis patients. We don't deem that you have any real substantial systemic absorption, so not going into the bloodstream, not affecting your organs, in particular, not affecting your kidneys.
That leads into this one. What about injectables? We inject a lot, primarily the knees, is where most of our cortisone is injected into the knees.
Cortisone's not a non-steroidal anti-inflammatory.
No, but I mean, how do you feel about depomedrol and kidney function? No issue.
No issue.
Okay,
No. There's no specific kidney guidance other like outside what you would do in the normal population.
Okay.
That doesn't have kidney disease.
Wow, there you go. And of course, we looked at the effects of non-steroidal anti-inflammatories from a nephrology lens. So of course, as we alluded to, there's bleeding risks, there's GI risks, ulcers, bleeding ulcers, other bad things that can happen. We know, and we talked about that in other videos, but today we just want to talk about kidney function and anti-inflammatory use, and that's why we had a great nephrologist here to tell us about this. So we really appreciate you sharing this and helping people out, helping people understand how non-steroidal anti-inflammatories can affect your kidneys.
Okay, now you know the safe amount or what you should be talking to your family doctor about when it comes to anti-inflammatories and your kidney function. If you like this video, please like it, subscribe to our channel, share it with someone that you know is maybe taking too many anti-inflammatories.
Thank you again for sharing your wisdom. Remember, you are in charge of your own health.
We'll see you next time.